Let's get going. Welcome everybody. It's a great privilege to welcome Jaap Seidell back to Cambridge. He keeps it quiet on his website, but he was actually here between 1980 and about 1982, taking courses in nutrition as part of the Dun unit, which was based in Old Addenbrooks. Hard to imagine now, but
Trumpington Street.
In Trumpington Street. And since that time, he's really forged obesity research in the Netherlands, leading figure at the Free University of Amsterdam, leading figure now in the merger between that university and the Amsterdam Medical Centre, creating Amsterdam Public Health, which has got 1,000 people, huge enterprise. But the reason we asked Jaap to come today was to talk about the very innovative and exciting work he's been leading on childhood obesity in the city of Amsterdam, which is really a great honour to hear about. I've heard him talk about it before, and I thought it would be great for us in the Institute of Public Health to invite and welcome Jaap today. So Jaap.
Thank you, Nick. Well, it's great to be back again. I looked at Old Addenbrooks this morning. It was the same from the outside. We were housed above the psychiatric ward, I remember, which meant that there was, because people were wandering around in nightgowns, it was 30 degrees all the time, and people were making strange noises, and we would go out and look what was happening. But that was, another time. Nutrition, well, Cambridge was famous for nutrition, public health nutrition at the time. Also. It still is, but it was then the leading institute in the whole world. So it was an extremely exciting time to work there. And they were discovering all kinds of things, like uncoupling protein, all these sort of things were happening in the next lab, and it was really nice to be there. So I will talk a little bit, not much about research actually, a little bit, but much more about policy and practice and research and the combination, how we can forge that together in doing something about these epidemics of non-communicable diseases. And I will focus on childhood obesity because that's where we started, but it's of course part of this. Well, this is Amsterdam. Most of you have visited it on stag parties or otherwise conferences and things like that. This is how we like to see Amsterdam, and we have physically active kids. There hasn't been any ice for the last 5 years, but it still sounds romantic, but cycling is still there. Everybody cycles probably kids can cycle earlier than they can walk. So we're active, but we have quite a lot of obesity also, like everywhere else where we're looking at urban areas. And I'll briefly make an excursion to Bradford Hill because I think that's interesting, because it's a Bradford Hill seminar. But all of this. This is how we think about managing the non-communicable diseases iceberg. Lots of, in the Netherlands, there's 1 million people now with type 2 diabetes, which has been exploded since the early 1980s. And what we usually think about prevention is treating people with high risk, which is all good. So there's 4 million Dutch people and a population of 17 that are treated chronically with antihypertensive drugs. And about 1.5 million with statins. Lots of emphasis and money and resources going into preventing, say, cardiovascular disease or diabetes by picking up the high-risk individuals. But we also, of course, know that behavior is part of that. I don't need to introduce that kind of notion here. There's very little treatment options or preventative actions on an individual basis there in our country. But we also know that, and I always copy this from Jerry Morris and all these other great people, that really the drivers, the social determinants of these behavioral risk factors are these. And I was thinking about Bradford Hill and about his assessing causality list and thinking about these illiteracy, poverty, food environment, and this list. You don't get very far. At least I didn't get very far by proving causality by old handling. So This is really very nice for high blood pressure or maybe intake of vitamin C and certain kinds of health outcomes like LDL cholesterol or whatever, but not so much for these social determinants of health, like a biological gradient. I'm usually talking to people who are really versed in evidence-based medicine, and I'm telling them about the social drivers of all these non-communicable diseases, and they will say, well, we don't believe that actually. If poverty is a determinant of diabetes, and if we give people 500 euros, will they actually be healthier? Will the diabetes go away? It won't, but then it's not causal, right? So I thought it was interesting to think about the strong emphasis on Bradford Hill's criteria and the poor show we have on, say, the upstream factors in relation to this. This is also why lots of people are not bothering with all of these sort of upstream factors, because it's so difficult to prove that you're effective. And it's also very difficult to prove, I mean, look at childhood marketing. Is childhood marketing of unhealthy foods, is that a determinant of obesity? How sure are we? Well, anyway, it's good to think about it. I got to think about it by preparing this because it's called the Bradford Hill Seminar. I like this also. I just came across it and I put it up. It takes a while to sink in, probably. But he actually makes a very good point. We don't need all the evidence to postpone action. I think that's a great quote of the person that actually determined that you need causality and proof of causality first before you do anything. But actually he didn't think that. He thought, does not confer upon the freedom to ignore the knowledge we already have to postpone action that it appears to demand at a given time. So, anyway. So, I'll make a brief excursion again to British history, I guess. But it's basically about Chadwick and the whole area in the 19th century where people really thought about social determinants of disease for the first time, I guess. And of course, you know, this is the area of infectious diseases, but the kind of thinking around that in the medical establishment is really quite interesting, I think. So they noticed also that actually there was a social gradient in disease, and so it must have something to do with what they do. And this is a quote from the public health officials, I think in New York. Basic problem with the poor lay in their lack of moral fiber. The poor have no one but themselves to blame for the diseases, and they need to be taught a combination of personal hygiene and resistance to sin. I have almost exactly the quotes of our national politicians, but also British politicians, I don't dare to name their names, that exactly say the same about obesity. Word for word. A lack of moral fiber, self-blaming, need to be a combination of personal hygiene, lifestyle, and resistance to sin. So the kind of thinking about this is very similar. And then, of course, we had Edwin Chadwick, who for the first time actually was quite a controversial person. And he said it's actually not about behavior and choices and individual responsibility. It is really the environment where poor people live in, the working and living conditions. And he was very successful in creating this whole movement to build sanitary sewers and remote moving, all kinds of other things, and ensuring clean water. I'm making this excursion for two reasons. First of all, because that happened at the same time also in Amsterdam, although they didn't know each other at all. But also that this actually worked without any evidence. There was no evidence that this was, they didn't know about bacteria causing cholera. But they forced cities to build water and sewage systems, brought improvements in housing and work conditions, and it eliminated basically infectious diseases epidemics, and death rates fell by 55%. That's an enormous improvement in public health, without any evidence, but looking upstream factors and environmental conditions rather than individual behavior. because this all happened before we had any sort of successful treatment or any understanding of what caused it. So I think that's important also to not exclude this also when you're thinking about other problems than infectious diseases. So we had the same problem in Amsterdam. Actually, there's a map from 1811 or something like that where they mapped out cholera. There were conspiracy theories also around this, but clearly also the poor areas had more cholera. Actually, quite ironic maybe is that the poorest area were in the middle of the center, which is the most expensive part of the town now. And also the Jewish quarters had less cholera. And that led to the suspicion that actually the Jewish people were actually contaminating other people with some sort of things so that other people got ill and they were protected against this. But of course it was their religious practices that meant that they were, by cooking practices and hygiene, were actually protecting them against this. So, but it's interesting to think about the moral dimensions about infectious diseases in an era where they didn't really understand what was causing them. Anyway, I'm telling you also this because in Amsterdam we had also a physician, a Portuguese Jewish originally. His great-great-grandfather migrated when in Portugal the Jews were expelled from that country, and lots and lots of them, including Spinoza and other philosophers, were living in Amsterdam. And he was quite a well-established figure. As a young man, he was medically trained, did a PhD on iodine in fish and things like that, nutritionally very interested. Born in 1813. And at the sort of moment at the age of 25, when he was establishing a career as a scientist and a professor in Leiden, he determined himself to become a poverty doctor in the poorest areas of Amsterdam. And that's what he did. He looked at all of the problems and decided that actually it was the environment causing all of the health problems in these communities. And single-handedly, he started a sewage system to have house disposal removal. I'm not sure if that's the correct term, but also all kinds of things about nutritional status. He was fighting the bakers because the bakers had a cartel in Amsterdam to keep the bread price high, and so poor people couldn't buy bread, and so he crowdfunded a bread factory. I'm talking about a physician doing public health. He wasn't accepted by the local politicians because he was making trouble, asking for sewage systems and all kinds of expensive things, but clearly something which was the result of moral hygiene. And he was also accepted by the local physicians because he was doing the protocol treatment of cholera, which was magnetizing or bloodletting. But he was extremely successful in creating healthier environments, both in nutrition, in infectious diseases, loads, and all kinds of other things. And when he died, he was extremely poor and not accepted by anybody. But when he died, there were 10,000 people lining the streets to the cemetery because the local citizens, they knew. And so Safati is an interesting name. We have a Safati Street, we have a Safati Park. And if you ask Amsterdam people if they know Safati, they said, yeah, it's the park. But they had no idea who he was. But he increased the life expectancy of poor people in Amsterdam by 15 years. In just a couple of decades. It's extremely interesting. Why am I putting this up? Because we looked at childhood obesity and said, why don't we take the vision of Safati and apply it to non-communicable diseases? So we have a new institute called Safati Amsterdam, and that's to honor also his vision, but also to determine that we are really looking at environmental and upstream factors that are causing disease, and seeing if that helps us to do this. And there's more connections. Tom Farley wrote in 2001 also in similarities between cholera and obesity, and I wrote in a national paper which was thought to be very controversial, in which I called obesity the cholera of our time, which nobody liked because it was clearly not an infectious disease. But but you know, have the idea where it's coming from. Actually, it is a social disease. I'm not sure if you've seen a recent paper in JAMA Pediatrics where they showed that families from the military services, they moved to different areas, and the BMIs of the kids actually were getting similar to the average BMIs where they moved. So if you moved in the low BMI neighborhood, same social backgrounds, by the way, all the same factors, then your BMI would go up, or go down. If you move to another area, then it would go up. And you know this probably also. There's some sort of social contagiousness of obesity. I won't get into this, but the similarities between non-communicable diseases and communicable diseases are more interesting than just dismissing them as being totally different. So, getting this perspective of Sapati, it means that what he did was intersexual collaboration and co-creation of values, whatever you call it. But this has been, of course, thought through many times. There are many reasons why we need to have intersexual action, and I will show you why we didn't, why it's rarely done. We know it is something that's necessary, but also that we have organized everything so in such a way that it's discouraged all the time. There's no incentive for working across sectors. The accountability and financial structures don't conduce it. This is interesting from Bradford Helper perspective. Effectiveness, you know, why does somebody in transportation has to work on obesity, or you know, sort of these sort of things. And there is no political will and leadership. So we know from the early days of public health, the Algren and Whitehead, 1991, clearly established as the basic foundations of public health. We don't do it often because everything works against us. I'll give you an example, and some of you may already have seen this, but it's called the Amsterdam Healthy Weight Program. But before that, I will say that we wanted to mix Sarfati with also clinical and methodological sound scientific work. So we decided to persuade, or we were able to persuade the local government, the Amsterdam municipality, to invest a lot in an infrastructure for research. So we have a municipal health service where all the children are being seen from birth, or even before birth, until they're 20. And we decided to have a basic dynamic cohort of all children living in Amsterdam, with 11,000 coming in every year, new ones, newborns, and then 20 years old leaving, where we have routine measurements of everybody. And that's an infrastructure we can use for more in-depth research, but also for doing randomized controlled trials with a 99% participation rate in the control area and no spillover effects and things like that. I can get into more details later if you like, but that's the basic infrastructure. So for evaluation, we have a quite good insight in all the individual data of children growing up in Amsterdam. This is the political and practical part of that. First, we persuaded the local government we had a national program which started with the idea obesity is, of course, first of all, a personal individual responsibility. And the choices around behavior are individual responsibilities, and it's about lack of exercise and unhealthy diets. And I said, well, if that's going to be the premise of determinants of obesity, that's not quite like Sarfati would think. So the program that's now up and running for 5 years or so is the risk factors for obesity are, no behavioral stuff, it's the upstream ones: poverty, cultural backgrounds, limited education, and urban environments, basically. So really upstream, right? So that's quite interesting from a public health point of view. We didn't have any other example of local programs that took this approach that actually it's the upstream factors that are causing the obesity problem. And we were able to convince them by mapping, as the cholera map, mapping obesity in the different neighborhoods. And of course, great, you know, in one neighborhood, 5%, in another adjacent to it, 35%. No. And we were able to show it's not really the behavior, or it's not the, it is behaviorally modified, of course, but it's driven by these sort of factors. Amsterdam is, I think, interesting because it is a multi-ethnic population. Like you have many towns in England that are very similar. So we are also able to address these things, socio-economic position in many different ways. What is, I think, interesting is the mission and the vision and the strategy, because from a public health point of view. For the first of all, this is started officially in 2013. There were many things happening before that, but officially it started in 2013. And the mission is for all Amsterdam children to have a healthy weight in 2033. It sounds very easy, but it's a 20-year objective for political people. You know, that's almost immoral for a politician. We never think more than 3 years ahead. Right? And it was also underwritten by all of the sectors in the city. So all of the aldermen or people in the different sectors responsible for anything about public health were also co-signing this. No child in Amsterdam will have an unhealthy upbringing. So the long-term perspective is needed, we know that, but is never achieved because people think in 4-year terms in elections. Then the vision. The Ministry of Health put out the 2013 program and said healthy weight is an individual responsibility. And so the City of Amsterdam completely contradicted that by saying healthy weight is a collective responsibility. It's only one word difference, but it changes everything. You know, so. And a healthy choice should be the normal choice. Everyone is needed. I think this is from Hillary Clinton, right? It takes a village to raise a child. Anyway, everybody is needed. It's a collective responsibility, which is really also what Safaki thought, but not what normal right thinking. I mean, right. I don't mean left or right, but then well-thinking politicians will think. The strategy is a healthier behavior in a healthier environment, putting the emphasis on the environment and removing unhealthy factors from the children's living environment. So it's a very upstream, long-term, and environmentally driven program. I think it's important to say that because it's that's really why I'm liking it so much. So it's a programmatic approach that was leadership, the alderman of our city, which is actually quite a liberal person. He's from the most right-wing political party that we have, that always thinks about autonomy and individual responsibility, took the leadership and said, I'm creating a healthier city for kids growing up here. I'm making them possible to make that choice and being autonomous by creating healthier environments, which is sort of changing it and still thinking the same. That only politicians can do that. Intervention, development, implementation, integral collaboration, intersectoral, and that's something we highlight very much, because when we talk to politicians about research, the level of energy in the room goes down. It needs randomized controlled trials, it needs PhDs that will spend 4 years or 5 years, and at the end you'll have a thesis which says more research is needed, little effectiveness on this program, we don't know if it's sustainable. Sorry about that, not here, but in Amsterdam. And so we said, let's call it something different. We call it the learning approach, which means you do something and we evaluate it, and by going, we will inform you why things don't work, and you can actually improve it and things like that. So then they like it a lot, and we said, you know, we're making your program more effective and better. And then suddenly research doesn't sound so ugly. Long-term vision and communication and marketing. I'll skip this. Right. You won't be able to read it, but it's in the newspapers all the time because these politicians are doing things that politicians are not supposed to do, like restricting childhood marketing, like banning advertising of unhealthy products in sports activities for children, by closing down shops and close to schools and all kinds of other things. It's really relatively unheard of, and especially by liberal politicians. You know? So it's this is some of the headlines. No commercials in sports or swimming pools. Only healthy offers in schools. Only water drinking in all primary schools. Yeah, no, it's quite a sort of almost North Korean doctrine. That's sort of how some people describe it, by liberal politicians. You know, what is happening here? So that's interesting. We got people so far that they, in these intersections, they are all happy to contribute for their own reasons. The people from education are happy because it would create school performance, more involvement of parents, and all kinds of other things, goals that they would like to achieve without any objective on childhood obesity. Transportation and safety in neighborhoods by reducing the traffic and more walking and cycling, reducing environmental pollutions and all kinds of, and increasing safety. We have a whole list of these co-created values that everybody says, I'm signing up for this because I'm, more social cohesion, more, and so that's really interesting. We do have a strong emphasis on evidence-based interventions, but not just because they are being randomized controlled with a p-value of less than 0.5, but also because they must fit in the context. They must be aimed at reducing socio-economic health differences. Maybe it's the abbreviation, but anyway, that's what we call it. They should always target the low SES groups. They should be in line, of course, and they must be in line with existing working methods. And we modify them all the time. Because usually interventions don't work in transporting you all over. So there's been a lot of investment in all sorts of other things than really interventions, which means looking at the long-term policy of town planning, of transportation, of creating educational programs, and looking at recreation examples and things like that. So that's really been quite a lot of the components, which is usually outside the realm of research, right? But we are investigating how these things work, why they work in some cases, why not in others, and how you can foster this intersectional collaboration in a meaningful way that makes the change, because you can never do this as a scientist on your own. You need to engage with the practice, political infrastructure. Well, I already mentioned this when I was here in Cambridge. They were already thinking in terms of public health in this way. Dalker and Whitehead, it was 1991, sort of solid background for all public health, but almost never implemented for some reason. So in Amsterdam, they looked at this and said, it's agriculture. It's also integrated food policy. By the way, I'm not going to spend more time on saying this, but we created a food council, a regional urban food council, which looks at sustainability, economics, and social inclusion and health of an integrated food policy, urban food. So that's part of it. Education, working environments, poverty, health, healthcare. Sports, healthcare is not as usually overlooked because that's separate. And I'll tell you a little bit more about that also. These environmental factors will then shape largely collectively individual behavior, and then of course it will affect families in a positive and meaningful way. So this is being all worked through in all kinds of sectors in making smart goals. So this is a 20-year objective, but every time it's split up in every 2 or 3 year programs that are actually raising the bar all the time for the next step. Well, so what is, I think some of the unique And Dolly Tays, you evaluated that and made a report out of this, and some of these, what we think are the essential elements, if you can call it that way. Multi-annual plan with a mission of more than 20 years, strong administrative and policy support. This actually costs money, but it saves a lot of money. I mean, if you look at all the outcomes that we are creating, nobody's against this. So there's been no objection against spending money on creating healthier environments for children so that they can grow and develop themselves optimally in physical, mental, and social ways. It's almost impossible to be against that, you know. So we've had a change of local government. Well, next, I think soon for the 4th time, but there's no disagreement. Nobody wants to disband this program. Because if you do, you say, well, we're not going to invest in children, we're not going to invest in future development or healthier environments. That's somehow become politically impossible to tackle. Ownership among those involved is encouraged. I will tell you a bit more about this. And we are aiming for permanent changes in the behavioral structure of the town. Attention to health and policies, long-term earmarked budget for integral approaches, very important, it's written in the law. So if a political party wants to disabandon that next year, for instance, they have to change the law. It takes 4 years. That's a waste of time. Sufficient, it's being thought through, you know. So this is what we did before. We had written in a program which was always lasting 5 years, which is always longer than sufficient capacity personnel. Okay. Skip this also. So the goals, the behavioral goals are relatively simple. Physical activity, less sedentary time, improved sleeping quality. That's a very central part of it now because it's been shown so many times that good sleep in childhood but also in adulthood is so integrated into a healthy lifestyle. But it's never addressed, at least not in our program so far. And of course healthy nutrition. So the schools have all signed up because it's almost politically incorrect not to sign up to be a healthy school. That means only water drinking when you're at school, only healthy school meals. You can only bring healthy foods. The treats are banned from most programs. It's singing and dancing and a little hat, which is when you're having your birthday, which is fine by everybody, especially by the teachers who are struggling with all the glucose, the gluten intolerant and the allergic and the demands of all the individual children. It's a huge relief to the parents, and the children like it just as much without any of the treats, the muffins or the cupcakes. This is quite central also. Engaged community. Almost all of the efforts, and I think more than half of all the efforts are engaging the community. They have people living in these deprived areas where they're completely immersed in the community and trying to create all kinds of events and activities with the people that are encouraging physical activity, healthy diets, and all the rest of it. The built environment is important. And then, which is something difficult, we want to integrate prevention and healthcare. So there's no difference. With the idea that if you prevent children from becoming obese, they need less healthcare. If they need healthcare anyway, because they're still obese, they get back to neighborhoods where it's easier to sustain the behavior change that they've learned. And actually to remove the barriers from this. So the healthcare programs, which say aimed at these children, are now community programs rather than hospital-based programs. And I was just explaining it this morning to somebody. For a family, the existing evidence-based integrated health programs in hospitals were meaning that during a work day and a school day, you had to visit, first get your car, get to the hospital, park, pay, get to a pediatrician, to a physiotherapist, to a dietitian, to a psychologist, to a social worker. And very, very strong evidence-based program. 90% drop out in 3 months. Why? You know? You can't do it. You know, it's impossible. It sounds logical from a healthcare provider's point of view, but it's not working. And so now we have community groups in neighborhoods. Paul Italy knows about this more than anybody here, I guess. We've learned and stolen some ideas almost everywhere, including these. But that is the idea, to have continuous sort of engagement of healthcare provision in neighborhoods and integrated with preventive actions. Sorry to be so long-winded about this. Training. This is funny. These slides are actually from the program. Lobby the food industry. It's not lobby the food industry. They're actually putting the thumb screws on the industry and the people that sell the foods to create healthier and offering in canteens or in sports facilities or all kinds of other things. But anyway, so they're engaged also. This is why whenever some people are extremely upset about that we actually engage with shop owners and all kinds of other things, and people that sell food in supermarkets, because they think it's immoral to talk even to people that are in industry. So when I was announced here, some people in the Netherlands thought it was very important to bring up that any engagement with the food industry is strongly disapproved by them. Anyway, it's important. I'll tell a little bit more about this. So, what have we reached so far? It's only a few years. 102 primary schools, that's almost half of all the schools. It's about close to half of the pupils reached. We have pilots in 16 more schools, so it's increasing rapidly. New action plans, lots of experiments with augmented reality that you've all seen and they've all gone again. You know. Anyway, we put everything in place when there's something like that. 58% of the sports event is child marketing proof. That needs to get to 100 very soon. We thought that would mean that there would be no sports activities, which is shooting yourself in the foot, but it's actually not true. People are very clever in finding new sponsors from other areas. There are 1,300 of these children's special care programs, which are low. I'll tell you a bit more. 100 health ambassadors. These are local people, citizens, that are actually promoting this whole idea. Be a bit more quantitative. Breakfast eating is pretty good also. You know, this is small differences on this, but there's a little increase in fruit and vegetable eating. There is a strong reduction in sugary drinks. So these are the quantifiable. So it takes time, because there's compensation in the early cases that if you cannot drink sugary drinks at school, you get some at home. So, you know, that's you get more than at home, because you're already eating vegetables, you don't get any at home. So this is slowly addressing the problem that you need to engage the parents as well, and that you need to, for a long-term change, this is early stages.
Sorry, is that self-report data? How are these measured?
Yeah, we have no, yeah.
So self-report from parents?
Yeah.
Thanks.
Most of these, BMI is not self-reported, that's measured in all kids. And you do see in terms of obesity, there are some reductions here. I have some more results here. Different groups. The largest decreases are in the highest risk groups, which is very important because we want to reduce social inequality. So this difference is larger than this difference. And here there's little to gain, yeah, as you can see. But in most groups, there's actually a reduction. And you can see it here a bit more, that this is now split to the education level of the parents. That, of course, there's a strong inverse gradient with increasing levels of education. But you also can see that there are drops, particularly in these low SES groups, which is very encouraging because these were the groups that were determined to be unreachable and resistant to change. So that's important because we seem to have a handle on these kids. These are not great reductions, but they are in 2 years. So it's whereas in towns where there were no interventions, comparison towns, there were no changes, increases or stabilization. So this is promising. So Amsterdam is part of a larger program on looking at these local integrated programs. And that national program is called JOKE, and it's also about effectiveness in these different elements here. But it's also about scalability. So every month we have new towns signing up for this. And they actually sign up to quite a lot of things. Long-term thinking, integrated intersectoral approaches, improving healthy environments for kids, and all kinds of other things. These signs won't tell you anything, but they're the town signs. When you enter the town by car, this is what you see. From all over the country. This is outdated. There are now 136 communities out of 400, which is sizable. The potential reach was 832 a few years ago. It's now more than 1 million. And in 12 of these communities, there's already a drop in obesity rates, especially in the low SES group. So this is not only doable, it's also scalable because there's a network of aldermen, but also of people working in these programs that regularly meet every 3 months or so, where they exchange their experiences and their results and solutions to problems. So it's accelerating, both in terms of scale and number, but also in terms of intensity. Something which made me very uncomfortable a couple of years ago was that we decided that most of the interventions in my group were either ineffective or not sustainable. When I studied nutrition in the 1970s, a long time ago, 5% of the Dutch population adhered to the national dietary guidelines. Now it's about 40 years later and it's 5%. So no change. So we've been sort of barking up the same tree all the time, doing interventions, doing top-down, short-term interventions with little result and no sustainability. And we decided to take another approach. This is what we did. We were mainly aiming at more papers, higher citation rates, and more funding, particularly because we wanted to sustain our own research groups. And the priorities actually were pretty much determined by the funding agency. So if the national program said, we want RCTs on this and that, we wrote grant applications, were funded, and then 4 years later, we had a PhD program finished and some papers. The role of the researchers, the director, and this is the methodology chosen. RCTs, measurable, quantifiable results. And so we sort of started to think that maybe this doesn't work in public health. Thinking also about CIPH. No evidence, doing things, great results. So we embarked in some reschooling in participatory action research. So what is the research for? Action. Who is the research for? Local people. Whose knowledge counts? Local people's count. Actually, they know a lot about their own environment. Who influences the topic of choice of research? The local people. What is the researcher doing? He is only facilitating and being a catalyst in these developments. It's the learning approach, if you like. And the methodology is empowerment and mutual learning. this was really uncomfortable, because when we would write applications, we would say the intervention is still to be determined, not funded. We needed numbers to treat, we needed power calculations, we needed precise description of all the interventions that we're going to do with measurable outcomes in specific times. And then we know that doesn't work, but we kept on doing it. So this is more difficult. But there are actually funding agencies that actually approve of this. So we've started a participatory action research institute in a deprived neighborhood run by the local people, where our researchers are visiting and trying to facilitate and catalyze and then observe, modify, all kinds of other things. But they are in a completely different role. Our experience now, I've evaluated this a few years later. The local politicians like it more. The researchers have a lot more fun. They're thinking they're much more effective also in getting things done. And the local people are much more inclined to work with us, to work on a long-term basis to improve the health of their children, which has been quite different previously. So it's a bit of an excursion, but I think it's not unimportant to think about other ways of doing this. So this is an example of it's a very simple observation. Only 1% of the children in Amsterdam eat enough vegetables. We asked them, if we do an intervention, will you eat more vegetables? And the answer is no. And actually they never did in any of the interventions we did so far. Then we started to evaluate a school garden program in which the children are spending a year, every week a few hours, with, under guidance, a local school garden program where they work the field. 95% of the children after this program said, I like vegetables. Were they eating them? Yes, because they were preparing them themselves. Was anything left of the vegetable soup that they were making? No way. Everything was good. Can be fun. Anyway, so just some pictures. And engaging the parents with this program actually made that children understood more about basic foods. They had a different taste and other attitudes to vegetables. They actually started to consume more vegetables as well at home, and they certainly wanted to have more of this. What is school gardening? It's a social enterprise. Children have to work together. It's outside, it's physical activity, it's educational for food and nutrition, but also about biology and soil and all kinds of other things. There's a complete endless list of benefits of school garden projects. This was actually created many years ago, first after Safari, but in 1929, where people thought that actually children need to learn about nature, biology, and food, and so we revived that program. Other program is collaboration with supermarkets, the big competitor against all interventions that we have to persuade children to eat more vegetables, because they can buy for almost nothing a lot of calories and sugar in supermarkets. They're always on sale and they're always at the counter. So we persuaded some supermarkets to change their offering, to remove the sweets at the counter. I know you do these things here also in the UK. But we work actually together with some of the people in Southampton that are doing similar research. But also we created healthier options, and you will not be able to see this, but usually when you are at a railway station, a Mars bar costs 60 cents, I don't know, 70 cents, who knows?
Who's going to admit?
No, nobody knows. Nobody's ever seen one. Anyway, but an apple is just as much, at least, or more. So we persuaded the supermarket to have the kilo price and divide it by the number of apples and then sell them for 15 cents. Right? So it's a big difference. So it's very cheap, it's accessible and it's really upfront. And this works. I mean, not to the advantage of the supermarket, because they lost a lot of money in our first experiments, about 800 euros per week per counter, which means we are hugely successful in discouraging children to buy sweets in the supermarket, buy this stuff instead. And so we're creating now sort of business opportunities that can prevent that loss of income. But it's clearly something that helps. Another thing that we've done is to have peer education. You know, teenagers are hopeless, but we have a lot of teenagers working in these shops, and then we train them actually to give health care, health information and dietary advice to kids, both in schools as well as in the supermarkets. And this is training of some of these guys. And also that we did in a randomized control. This helps enormously. If the super cool guy in the supermarket tells you that actually if you drink an energy drink, you're quite a loser. And if you really want to be like him, you know, you drink bottled water or whatever. That's actually very convincing, much more so than anything else that we've done so far. So very, very persuasive. And actually what we found is the supermarkets evaluated is also broader, that these kids are getting known in the neighborhood as the health people. So they have a lot more, you know, mothers coming up in the street showing the contents of their bags to these guys. Just, I'm doing good, right? So it's a lot of social effects. We do these sort of things, so you all know this, like supermarket safaris, and getting to know what's in there. Also, we evaluate programs, of course, on BMI and reported intakes and things like that. But also, this is a childhood obesity treatment program in which the children have to describe how they felt before and how they felt after. So you don't need the language. This is bullying, tears, more bullying, etc. After. Much better. Now. So this tells us more about things than SDS BMI points. It actually tells children they're much more comfortable in their lives and easier to go on with being at school. And we think, I personally think, maybe this is more important than all these quantifiable things. Anyway, so just a brief excursion to public-private partnerships. This is what lots of people get upset about, and so what we do, and rightfully so. There's lots of bad examples of doing this. So we've created sort of a, I know you've been talking about this, that's the told me, so I'm giving my perspective here. So what we don't think is good public-private partnerships is donation, funding, sponsoring, sales agreements, license, fusions, or anything that calls an alliance. We're all in this together and equal partners. Doesn't work. We think that there's also a PPP concession model, which means there's a policy program, basically evidence-driven. Public party develops policy and looks for partners for execution and implementation. This is why you need these guys, because you can't change the food environment without the people that sell it and market it. And what's very important, the public party, which is the government, for instance, is directing it and is mandatory. But you do need engagement with all kinds of people in the food environment to make changes possible, but also to make them sustainable and lasting. So this is an example. We have a network of entrepreneurs, healthy entrepreneurs, Amsterdam. Very fancy name, but it's usually small shop owners. Little shops, 7-Elevens, but also small supermarkets, but also recreation facilities like museums, the zoo, and all kinds of other places where kids get to eat unhealthy foods. And increasingly these parties are signing up because they want to be part of this movement. In this neighborhood where there's lots of things happening, these two guys have a Turkish shop where they've removed the sweets from the counter, but they've also removed the energy drinks, and they're changing it to water and to vegetables and fruits. So the conclusions are people are already leaving. Effective local integrated approaches are possible, and they're affordable and scalable, but they require intersectoral collaboration and co-creations of outcomes of activities. I think we need much more participatory action research and research action guided, and it requires a long-term vision to create health-promoting environments. Thank you.